Welcome to Phoenix Medical Lectures. In today's video, we will be seeing Endocrine Pancreas Part 1, which constitutes the introduction to endocrine pancreas and insulin. So here we have the diagram of pancreas. First, we will see the parts. This portion is the uncinate process. This is the head, the neck, body, and the tail. So, in endocrine pancreas, islet cells of Langerhans. This constitutes the endocrine part of the pancreas and it is scattered throughout the entirety of the pancreas, but the tail portion contains more of it. So, this islet cells of Langerhans constitutes about 2%. 2% of the body weight of the entire pancreas. So this is the introduction to endocrine pancreas, and this islet cells of Langerhans contains 5 different types of cells, namely alpha, beta, gamma, delta and PP cells. So now we will see what these individual cells secrete. So this is alpha cell, it secretes glucagon. The beta cell secretes insulin, delta cell secretes somatostatin, and PP stands for pancreatic polypeptide. So glucagon and somatostatin are also secreted by the mucosal cells of the upper GIT. That was about the introduction of endocrine pancreas. Now coming to insulin. Insulin is a hormone which is secreted by the islet of Langerhans. So this is the structure of the insulin. So this is B chain and this is A chain. So the insulin is a structure which contains 2 chains of amino acids, A and B. So these 2 chains are linked by a disulfide bridge. So this is about the structure. So A chain contains 21 amino acids and B chain contains 30 amino acids. So B chain contains 30 amino acids and A chain contains 21 amino acids, and this is the structure which is joined by 2 disulfide bridges. So now we will see about C-peptide. So C-peptide it constitutes of 31 amino acids and it is secreted along with insulin in equimolar amounts. So what is the importance of C-peptide is that, so this level, the level of C-peptide in blood will provide an index for the beta cell function. I'll mention it. So it will provide an index of the beta cell function. So why is this important is that this is seen in patients who are administered with exogenous insulin. When patient is administered with exogenous insulin, their beta cell function is verified by the blood levels of C-peptide. So the concentration of C-peptide in the blood is estimated by radioimmunoassay. So the C-peptide is secreted along with insulin in equimolar amounts and it contains 31 amino acids, and the importance of C-peptide is that it is used to estimate the beta cell function in patients who are administered with exogenous insulin, and the concentration of C-peptide in the blood is estimated by radioimmunoassay. So the blood insulin level is 10 to 50 units per ml. So this is transported mainly in the blood, it is in free form. So this is about 80% is in free form. About 20% of it is transported in combination with cyanalbumin. Coming to the metabolism of insulin. So normally the receptors are important because this insulin exerts its effect on various tissues by binding with the receptors which are present on the membrane of the cells. Next is that obese person normally tend to have few receptors, comparatively lesser receptors than normal people. This is one of the major reasons for insulin resistance among them. The third thing is diabetes. Diabetes is also a reason for impaired insulin binding, and there are 3 insulin inactivating systems. Collectively, they are known as insulinases. So these are insulin inactivating systems. So now we will see the action of insulin. So this is divided into certain parts. So the first thing that we will see is the effect on the membrane. Coming to glucose. So as far as glucose is concerned, insulin facilitates the entry of glucose into the cell for it to get metabolized. How it happens? So there is GLUT4 transporters. So the insulin normally increases the GLUT4 transporters, thereby enhancing the glucose entry into the cell. It goes inside by facilitated diffusion, it goes inside and gets metabolized. So this is the normal mechanism of insulin. In case of insulin deficiency, there is no increase in the GLUT4 transporters, thereby the glucose entering inside the cell is also reduced. So what happens? Glucose goes inside the cell from the blood. So there will be an accumulation of glucose in the blood which will lead to hyperglycemia. Okay. So this is amino acid and fatty acids. So another effect of insulin on the membrane of the cell is that it allows enhances the entry of amino acids and fatty acids into the cell. The third one is potassium. Insulin also enhances the entry of potassium into the cell, and how this happens is through the sodium potassium ATPase. So insulin increases the activity of sodium potassium ATPase, thereby facilitating the entry of potassium into the cell. So this is the combined effect of insulin on the membrane. It allows glucose to enter, amino acids and fatty acids to enter, and potassium to enter the cell. Now coming to the effect on metabolism. First we will see the effect on carbohydrate metabolism. So the first two here. Insulin inhibits gluconeogenesis. It inhibits gluconeogenesis as well as glycogenolysis. It inhibits these gluconeogenesis and glycogenolysis. So gluconeogenesis, it normally inhibits this by suppressing the activity of the enzyme which participates in gluconeogenesis. Now coming to glycolysis and glycogenesis. So glycolysis is promoted as well as glycogenesis. Both of these are promoted by insulin. So glycolysis is for the peripheral utilization of glucose by the tissue, and glycogenesis, the insulin will increase the formation of glycogen synthetase, so thereby it will promote glycogenesis. So the action of insulin is to reduce the blood sugar level. That is the reason for inhibiting gluconeogenesis and glycogenolysis and promoting glycolysis and glycogenesis. Now coming to NADPH. Insulin increases the NADPH levels. It does so by increasing the HMP shunt pathway. So this is the metabolism of carbohydrate. Gluconeogenesis and glycogenolysis is inhibited, glycolysis and glycogenesis is promoted, NADPH levels is increased. Now coming to fat metabolism. First, insulin promotes lipogenesis. So lipogenesis is the formation of new adipocytes. So how it does this is, normally there is extra glucose. When there is an excess glucose, it gets converted into fatty acids, which in turn gets converted into triglycerides. So thereby insulin facilitates lipogenesis. Because insulin facilitates lipogenesis, obviously it will inhibit lipolysis. It inhibits lipolysis by inhibiting the hormone sensitive lipases. So it inhibits lipases. Right. So the third and most important point that we've already seen is that insulin promotes the entry of free fatty acids into the cell. So in cell, in the sense adipocytes, fat cells. So what happens? The importance of free fatty acid entering the cell is that when there is insulin, normally when there is insulin, a normal level of insulin, the free fatty acid enters the cell and there is deposition of the fat. So suppose if there is an insulin deficiency in cases of diabetes mellitus, what happens is that the free fatty acid is not able to enter the cell as occurs normally. So this gets converted into ketone bodies such as acetone, acetoacetic acid, beta hydroxybutyric acid, all of these, and then this will lead to acidosis. So when there is uncontrolled diabetes mellitus, it is important that the free fatty acids might lead to acidosis. So diabetes mellitus should be kept under control. Insulin also tends to stimulate the hepatic synthesis of cholesterol. So these are the fat metabolism. How insulin aids in fat metabolism. So we already saw that Insulin facilitates the entry of potassium into the cell. So, where is this useful? Normally, when there is an acute renal failure, insulin is used. Exogenous insulin is normally administered to treat the hyperkalemia. It is used in combination with glucose. Why so? So, when the potassium enters the cell in the blood, it creates a hypokalemia. So in hyperkalemic patients, when exogenous insulin is administered, it will lead to reduction in potassium levels in the blood, thereby treating it. So now we will see the hormones which regulate the insulin secretion. First we will see gastric inhibitory peptide and glucagon like peptide 1. So these two hormones is when the food enters the GI and enters the intestine. Especially the jejunum and the ileum secrete these two hormones. They are released and they reach the pancreas through blood. When it reaches the pancreas, it stimulates the insulin secretion. So this is an anticipatory release of insulin because this occurs before the glucose is absorbed. So this will actually prevent the surge in plasma glucose. So this stimulates the insulin secretion. Second is glucagon. The glucagon is also secreted by pancreas islet cells of Langerhans, which is of alpha type. This cell will reach the beta cells and it will directly stimulate the secretion of insulin. So this also stimulates the secretion of insulin. Next, CCK and gastrin, these also stimulate the insulin secretion and this is released during digestion. Next is somatostatin. This is also released by the islet cells of Langerhans of the pancreas but of the delta type. Now somatostatin inhibits the secretion of insulin. Now finally insulin itself. So exogenous administration of insulin will lead to inhibition of endogenous insulin secretion. Okay, so GIP and GLP-1, glucagon, CCK, gastrin, all of these promote insulin secretion, whereas somatostatin and exogenous administration of insulin inhibits endogenous insulin secretion. Now coming to parasympathetic and sympathetic nervous system. First we will see parasympathetic. When there is vagal stimulation, it normally tends to increase the secretion of insulin. How this happens? So, ACH increases the intracellular calcium. This via the M4 receptors. So, acetylcholine via the M4 receptors increases the intracellular calcium. Thereby, it increases the insulin secretion. Coming to sympathetic. So, sympathetic nervous system. Its action is mediated by two receptors. One is alpha, the other one is beta. So when the alpha receptor is activated, the insulin secretion is inhibited. Okay, and when the beta receptor is activated, the insulin production is increased. Insulin secretion is increased when beta receptor is activated and is inhibited when alpha receptor is activated. So when we see the parasympathetic nervous system, it increases the insulin secretion, and the sympathetic nervous system, if it is mediated through alpha activation, then there is inhibition, and beta receptor is activated, then there is facilitation. So the disorders of insulin. When there is an decrease in insulin secretion, that is the most common disorder, which is diabetes mellitus. So diabetes mellitus is one of the most common disorders, and it occurs because there is a deficiency in the insulin secretion. And there is a rare disorder where there is increased insulin secretion, which is termed as insulinoma. Okay, so there are two disorders. If there is an increase, there is a rare condition which is known as insulinoma, and when there is a decrease in secretion, a common condition, diabetes mellitus.